So this is the personality disorders review for the PMHMP ANCC exam, and it is just going to be brief. There's not going to be too much effort placed into the graphics of the presentation because I am scheduled for my boards in the next 2 weeks, and I want to start to move a little bit faster. So I'm going to do personality disorders today, and maybe even also the pediatric chapter today. So we'll start with this one. Personality disorders are common disorders that can affect the quality of the general health care that a person receives. Although these disorders can create difficulty for the given person, he or she remains able to perform routine daily functions. Often, the person does not recognize a problem or seek treatment. Personality is the sum total of all emotional, cognitive, and behavioral attributes of a person. Personality involves an enduring pattern of perceiving, relating to, and thinking about the environment and one's self that are exhibited in a wide array of social and personal contexts. When healthy personality structures allow for realistic, happy, and satisfying self-perceptions and interpersonal interactions. Characteristics. Personality is organized early in life and is dynamic and deeply ingrained. However, it can be altered. Patterns of behavior based on personality can be perceived by the person as comfortable, which is ego-syntonic, or uncomfortable, which is ego-dystonic. Ego-syntonic is the behavior is consistent with personality, it causes little concern to the person, and the person generally fails to recognize that there's a problem. The person does not seek treatment with ego-syntonic behavior. Ego-dystonic is the behavior is inconsistent with personality, it causes discomfort and concern to the person, and the person generally recognizes that there's a problem. The person often seeks treatment when they are exhibiting ego-dystonic behavior. Personality disorders description. Personality disorders are chronically maladaptive patterns of behavior that cause functional impairment in work, school, or relationships. These disorders manifest as maladaptive patterns in 4 areas of functionality: maladaptive affective traits such as overly affectual patterns of response, maladaptive behavioral traits such as poor impulse control patterns of response, maladaptive cognitive traits such as unrealistic perceptual patterns of response, and maladaptive social traits such as maladaptive, unsatisfying interpersonal patterns of response. These disorders can cause subjective distress. A person is unlikely to recognize a problem or seek help if maladaptive patterns of behavior are ego-syntonic. A person is more likely to recognize a problem and seek help if maladaptive patterns of behavior are ego-dystonic. Maladaptive patterns are inflexible and pervasive across most personal and social situations. These disorders are coded in DSM-5. Clients seldom fit neatly into one personality disorder diagnosis, but rather they often exhibit features of several similar disorders. For this reason, the personality disorders are often referred to by the category of commonly manifested symptom clusters, A, B, or C. The etiology is multiple theories ranging from psychological to neurobiological, probable multifactorial etiological picture. There's less empirical data available on neurobiological etiological factors. Borderline personality disorder is the most well-researched. There are 2 types of theories of personality disorders. There's the psychodynamic theory and the biological theory. For the psychodynamic theory, it's primarily borderline personality disorder. It's based on 2 etiological factors. There's early separation problems and dysfunctional family patterns. Early separation problems are split up into object relations theory and failure in separation. Object relations theory is internalized intrapsychic experiences of interpersonal relationships, mental representation of the self in relation to others, stability and depth of a person's relationships, and during development, the child must accomplish 2 tasks: separation and individuation. Separation is to develop intrapsychic self-representation distinct and separate from the mother. Individuation is form a distinct identity with characteristics unique to the person. Failure in separation, individuation is ideologically linked to development of personality disorders. Different personality disorders are linked to problems with different stages of the separation individuation process. That is, disturbed parental interaction, family background assumed to be dysfunctional. That's when there's enmeshed family members, role reversal patterns of child-parent interaction, restricted involvement of family with the rest of the environment, social isolation, confusion of parental authority and nurturing roles, blurred family boundaries. And lastly, there's dysfunctional family patterns, block separation, individuation processes. The family rejection occurs if a person attempts individuation. Biologic theory includes genetic factors, structural abnormalities, neurotransmitter dysfunction, and neurobiological impact of the trauma. So the genetic factors are familial tendency, genetic overlap between loading for some axis 1 disorders and personality disorders. Structural abnormalities are reduced gray matter volume in the prefrontal cortex and the limbic system deregulation. Then there's neurotransmitter dysfunction, which is decreased level of serotonin, elevated levels of norepinephrine, and dysregulation of dopamine receptors. That's the neurotransmitter dysfunction of personality disorders. And neurobiological impact of trauma. Most studied and borderline personality disorder assumes early childhood trauma alters basic brain patterns of response. In genetically susceptible people may function as the environmental vulnerability that causes the expression of genetic load. Incidence and demographics are difficult to estimate because people with personality disorders are rarely hospitalized and often receive no treatment. The incidence varies with the disorder, generally assumed to be 0.5% to 5.4% of the general U.S. population. Risk factors are genetic loading and dysfunctional family of origin. Prevention and screening are at risk, family education, community education, stigma reduction, of course, early intervention and initiation of treatment, and preventative work with young children in identified dysfunctional family settings. The assessment is symptoms of personality disorder are enduring maladaptive patterns of behavior, generally seen as problems with living. Often several interviews are needed to clarify the diagnostic picture. The history is assessed for the following: detailed history of present illness, including time frame progression, social history, medication use, initial and periodic functional history assessment, and validate the history with family member. Long-term patterns of functioning are stability of traits over time and across situations, and cultural issues versus maladaptive personality traits. Cluster A disorders are patterns of pervasive distrust and suspiciousness with odd and unusual behavior. They present in a variety of contexts without supportive evidence. Distrust usually is not at the psychotic level, but can display brief psychotic episodes under stress. Significant history includes limited social network, poor interpersonal relationships, limited disclosure, or revealing of self to others, often refusing to answer personal questions. Compliments are misinterpreted. Pathological jealousy is common, difficult to get along with, appearing cold and lacking in feeling, high control needs, rigid and critical of others, and often highly litigious. Negatively perceives others, often based on prone to stereotypes. Schizoid personality disorder neither desires nor enjoys close relationships, chooses solitary activities, and shows little to no interest in sexual activity with another person, derives no pleasure in social activities, lacks close friends and social supports, is indifferent of opinion of others, and appears cold and detached, exhibits affective flattening. Schizotypal personality disorder. They have ideas of reference, odd beliefs, magical thinking, that's schizotypal, unusual perceptual experiences, paranoid ideation, inappropriate or constricted affect. Behavior is overtly odd, eccentric, or peculiar. There's few or no close friends, and there's excessive social anxiety. Assessment for cluster B disorders. It's patterns of pervasive, affective, and interpersonal disruption. They present in a variety of contexts even without the support of evidence. Disturbances usually are not at the psychotic level but can display brief psychotic episodes during or under stress. Of all the clusters, disorders of cluster B type may require hospitalization during periods of active symptom expression and when the client is under significant stress. Significant history include the following: fluctuating emotional states, dramatic qualities to how the person lives his or her life. There's frantic efforts to avoid real or imagined abandonment, pattern of unstable, intense interpersonal relationships, identity disturbances, impulsivity often with self-damaging behavior, recurrent suicidal behavior, chronic feelings of emptiness, inappropriate intensified affective anger responses, and transient psychotic symptoms of paranoia or dissociation. Borderline personality disorder is predominantly in women, often with positive history of significant childhood physical abuse, sexual abuse, neglect, or early parental separation or loss. Antisocial personality disorder characteristics are failure to conform to social norms, repeated acts that are grounds for arrest, deceitfulness, lying, and the use of aliases to profit or pleasure, impulsivity and failure of future planning, reckless disregard for the welfare of others, and consistent irresponsibility, lack of remorse, indifferent to the feelings of others. Histrionic personality disorder is they are uncomfortable in situations in which they are not the center of attention. Interactions with others characterized by inappropriate, seductive, or sexualized or provocative behavior, rapid shifting, and shallow emotional responses. Consistent use of physical appearance to draw attention to self. Speech is excessively impressionistic and lacking in detail. Suggestible and easily influenced, and relationships are considered more intimate than they really are. That's histrionic personality disorder. Narcissistic personality disorder is a grandiose sense of self-importance, preoccupation with fantasies of power, success, brilliance, and beauty, belief of self-importance and being special and unique. Excessive admiration is required. Unreasonable expectations or sense of entitlement, interpersonally exploitative, empathy lacking, and envy of others and belief that others envy him or her, arrogant and haughty behaviors. Cluster C disorders are patterns of pervasive anxiety and fear. They present in a variety of contexts and even without supportive evidence. Disturbances are usually not at psychotic level, but they can display brief psychotic episodes under stress. Significant history includes the following: avoidant behavior, procrastination, difficulty in following through, fearful of rejection and criticism, difficulty in relaxing. Avoidant personality disorder. Avoidant personality disorder must consider cultural variables when looking at avoidant behavior. Disorder is equal for both of the genders. Their characteristics are avoidance of activities involving significant interpersonal contact, fear of criticism, disapproval, or rejection, unwillingness to be involved with people unless sure of being liked, restraint in intimate relationships for fear of being shamed, preoccupation with being criticized or rejected in social settings, view of self as socially inept, personally unappealing or inferior, and unusual reluctance to take personal risks or engage in new activities. And this is avoidant personality disorder. For dependent personality disorder is most frequently diagnosed. It's the most frequently diagnosed personality disorder. That's dependent personality disorder. The rates are higher in women than in men. It's commonly diagnosed in people with a history of chronic physical illnesses. Dependent personality disorder characteristics are difficulty making everyday decisions without excessive advice, needing others to assume responsibility for most areas of life, difficulty expressing disagreement, difficulty initiating projects by himself or herself, going to excessive lengths to obtain nurturing and support from others, urgent seeking of another relationship if a close relationship ends, and unrealistic preoccupation with fears of being left alone, and that's dependent personality disorder. Obsessive compulsive personality disorder, predominantly in men. Symptoms are similar to but less severe than obsessive compulsive disorder. Preoccupation with details, rules, order, and organization. Perfectionism that interferes with task completion. Excessive devotion to work and productivity. Overly conscientious, scrupulous, and inflexible on issues of morality. Inability to discard worn out or worthless objects. Reluctance to delegate tasks or work with others. Adoption of a miserly spending style towards self and others. Rigidity and stubbornness. Physical findings are nonspecific for personality disorders. Diagnostic and laboratory findings. The CBC can profile thyroid function tests to rule out metabolic causes and drug toxicity if indicated by history. Differential diagnosis, comorbidity is common, especially with mood disorders. Affective instability of borderline personality disorder, often mistaken for bipolar affective disorder. There's also substance-induced disorders. Clinical management is rule out or treat any conditions that may contribute to cognitive impairment. Personality disorders are generally managed in a community setting. In some cases, hospitalization may be required. Pharmacological management. There's no specific class of pharmacological agents used to treat personality disorders. Individualized symptom control. Impulsivity are selective serotonin reuptake inhibitors, or SSRIs, are good for impulsivity, and then there's anticonvulsants for mood stabilizers. Affective instability can also be treated with SSRIs and anticonvulsant mood stabilizers. And anxiety, again, also treated with SSRI, non-benzodiazepine anxiolytics, and benzodiazepines are used but with extreme caution. Non-pharmacological management are most common form of treatment for personality disorders. It focuses on issues of limit setting, protection from self-harm, improved coping, and enhanced interpersonal functioning. Multiple therapeutic interventions may be used, such as case management, psychotherapy, which focuses on the person gaining control, improvement of interpersonal skill level, enhanced coping, alterations of problematic patterns of behavior. The forms of therapy are dialectical behavioral therapy, psychotherapy, interpersonal therapy, behavioral therapy, CBT, and milieu therapy. Assist with realistic expectation formation, structure the environment, and improve realistic self-appraisal ability. Lifespan consideration. Children. Before diagnosis is determined, sufficient life experiences must occur so that chronicity of maladaptive patterns can be observed. Features of personality disorder usually become apparent during adolescence to early adulthood. It is unusual for someone to be given personality disorder diagnosis before the age of 16 to 18. An exception is antisocial personality disorder, which is often observable by onset of puberty. However, diagnosis of antisocial personality disorder is not made until the age 18. Separation, anxiety, and chronic physical illness often precede and predict the onset of dependent personality disorder. Follow-up. These are chronic disorders and clients may be resistant to change. Relapse is common and frequent. How long to treat and success rates vary with client characteristics and motivation. Prognosis is poor without treatment. Prognosis improves if the treatment is started as early in life as possible. All right, this is the end of this chapter. Luckily, it was pretty fast. And next, I'm going to start working on disorders of childhood and adolescence, which is chapter 15.